So here are the factors important for postprandial glucose excursions, which means after you eat, what will be the factors that control um, the high and low um, movement of glucose in the blood. So what determines whether glucose will be excessive or not? Number one, the load of carbohydrates, and that is a given. If you will be taking a lot of carbohydrates via food, then you will have or you will expect more glucose to be present in the blood. Another factor is gastric emptying rate. How fast does the stomach empty its contents into the duodenum? So if you have a high gastric emptying rate, then that means your gastric emptying time will be low and yung stomach will be outputting into the duodenum um, food bolus at a quicker rate, which means when this food bolus, which contains the carbohydrate, is emptied into the duodenum quicker, then this will be digested at a faster rate and therefore will be absorbed at a faster rate. So yung mga diabetic patients, they found out na meron silang inherent um, difficulty in regulating gastric emptying rate. So we also observe in them the phenomenon known as dumping syndrome, na kakapasok lang ng food sa kanilang stomach na empty na agad sa duodenum, and that will lead to spikes of blood sugar. The third one is digestion and absorption. So dito papasok yung quality ng diet natin. Kung ang kinakain natin is rich in fiber, then the glucose molecules that would normally be digested at a quicker rate will be digested at a slower rate because it is embedded in fiber, which is undigestible. So another factor in that is absorption. So yung kinain natin na carbohydrate, if we eat it alone, it will be absorbed much quicker. But if we eat carbohydrate together with protein, then the absorption of glucose will be slower. If we eat carbohydrate together with fat, then the absorption of glucose through the enterocyte or the small intestinal cell will also be slower. So next is the incretin effect, which we will focus on in this discussion. And last would be nutrient disposition and deposition. Yung mga na-absorb natin, ano yung gagawin ng katawan sa kanya, sa glucose na na-absorb? Will the glucose be metabolized to release energy right there and then, o isa-store pa ba siya? So ultimately, yung kinakain natin na carbohydrate will lead to an increase in glucose, and these factors right here, the load of carbohydrate, the rate of gastric emptying, digestion and absorption, the incretin effect, nutrient disposition and deposition will all interact to produce the observable blood sugar level. Okay, so let's now focus on the incretin effect. The definition of this is the amplification of insulin secretion, which occurs when glucose is taken in orally as compared to infusion of glucose intravenously. So what does this mean? When you give glucose via an IV line, isaswero mo yung glucose, i-infuse mo sa patient diretso sa dugo niya. Of course, that will raise the levels of glucose in the blood. And as what we have discussed previously, that will lead us to secretion of insulin by the pancreas. However, if you give that same amount of glucose into the patient through food, So dadaan sa gastrointestinal tract. If you compare the amount of insulin secreted, mas marami yung isa-secrete ng pancreas ng patient if the glucose comes from the food that you've eaten. So that amplification, yung difference na yun, mas marami yung nasa-secrete kapag kinain mo siya is what we call the incretin effect. So normally, the insulin response is augmented by a factor of 2 to 3 after oral intake. So what does this mean? Hypothetically, nag-secrete yung pancreas natin ng 10 units of insulin in response to IV infusion of glucose. But if that same amount of glucose is taken in through the mouth and digested and absorbed through the gastrointestinal tract, then hypothetically, the amount of insulin released would be 20 or 30. Okay, so this is one of the many ways whereby the organism copes with the intake of a carbohydrate load. So it all boils down to homeostasis. Ang gustong gawin ng katawan ay balanse lang, no? Nandun na siya sa normal. So ito kasi yan, pag wala tayong kinakain, bababa yung glucose. So yung homeostatic mechanisms ng katawan would try to increase the levels of glucose in the blood. That same principle also applies when we eat food. Kung kakain tayo, tataas yung glucose. And so, yung homeostatic mechanisms ng katawan would try to lower glucose. Para nandun lang talaga siya sa gitna. Balance lang siya. So the incretin effect is one of that response which tries to lower blood glucose after the stimulus, which is an increase in blood glucose after eating. So ito yung lista natin ng incretins. Actually, marami pa talagang incretins, but these two, gastric inhibitory peptide and glucagon-like peptide 1, sila yung major na mga incretins. So, ang other name ng gastric inhibitory peptide is glucose-dependent insulinotropic peptide. So i-break natin, try natin i-analyze yun. No? These two, itong mga incretins na to, GIP and GLP, sila ay tinatawag ng mga gastrointestinal hormones. So ibig sabihin yan, yung nagsisecrete sa kanila is the gastrointestinal tract. Whenever the gastrointestinal tract encounters food. Okay? So dito, whenever the gastrointestinal tract encounters glucose in its lumen, kasi di ba may lumen yung gastrointestinal tract. Kapag may glucose na dumaloy doon, GIP and GLP-1 will be released. So sabi natin, GIP has is also called as gastric inhibitory peptide or glucose-dependent insulinotropic peptide. So whenever the small intestines will encounter glucose, yung intestinal cells will release gastric inhibitory peptide, and that will go back into the bloodstream. From the intestine into the bloodstream, circulates and finds its way back to the stomach. And that will inhibit the stomach from emptying so that the intestine will have ample time to digest and absorb. Okay, so yun yung effect niya sa motility. But at the same time, yung other name niya, glucose-dependent insulinotropic peptide. Pag mayroong glucose na na-encounter yung small intestinal cells, this hormone, when released into the bloodstream, will lead to an increase in the release of insulin. Kaya yun yung pangalan niya, insulinotropic peptide. So, ito naman, glucagon-like peptide 1. It has incretin effects, but the structure is like glucagon. Kaya ang pangalan niya is glucagon-like peptide 1. So tingnan lang natin yung effects niya. GIP will lead to, and even GLP-1 will lead to beta cell proliferation. So ibig sabihin nun, tutulungan niya ang pancreas na padamihin ang kanyang beta cell so that the pancreas will have the capacity to secrete more insulin. The two will increase insulin secretion. But what's striking here is that in patients who have type 2 diabetes mellitus, glucagon-like peptide 1 will stimulate insulin secretion far more than GIP or gastric inhibitory peptide. So, ibig sabihin yan, mas effective sa diabetics if we give them GLP-1. You have glucagon secretion, GIP, gastric inhibitory peptide will increase glucagon secretion, but GLP-1 will decrease by manifold glucagon secretion na kung nag-review na kayo ng pharmacology is important. Glucagon is important in increasing blood glucose, and at the same time it is pathologic in patients with type 2 diabetes mellitus. Somatostatin increased secretion by both hormones. So tingnan natin itong special with GLP-1 na hindi natin makikita with GIP. So appetite decreased, food intake decreased, body weight decreased, effect of the vagus nerve, which is acetylcholine mediated, decreased. Gastric emptying is decreased. So ibig sabihin nun, babagal yung stomach sa pag-empty sa duodenum. So the effect will be a slower and more gradual digestion and absorption, which is good for patients with diabetic. We want them to be at the slow and sustained blood glucose elevation, not the spiking. Okay, gastropancreatic secretion decreased. Okay, but GLP will increase the heart rate. Okay, GIP will decrease bone resorption. Okay, so dito sila nagdi-differ sa baba, but the most important effect would be this one: beta cell proliferation, insulin secretion, and body weight. Okay, dito tayo sa body weight. So remember na yung central na problem with type 2 diabetes mellitus ay nagkakaroon sila ng insulin resistance, at most of the time that is associated with adiposity or increase na katabaan. No, so if we have a way to decrease the adiposity, then the natural progression of being overweight, being obese, and being insulin resistant, and then later on being diabetic will be stopped. Okay, so here we have a diagram which tells us the complex interaction of these incretins with the different tissues of the body. So you have, for endocrine transmission, GIP and GLP-1, they have direct effects on the brain, on the pancreatic islet, and in the adipocyte. Okay? So kanina nakita nyo na yung effects nitong dalawa, GIP and GLP-1. These two, the incretins, will have effects on neural transmission. So there will be direct effects back to the brain, and this is what we call as the gut-brain axis. Okay, the status of the gastrointestinal tract directly affects how the brain functions. Okay, islet cells, because again, it is intricate, no, yung regulation ng hormones from the GIT, the pancreas, with the nervous system. Okay, We have direct effects of circulating substrates sa brain, sa liver, sa adipose tissue, and sa islets. So substrates are sources of energy, and substrates are building blocks for the tissues of the body. Glucose, amino acids, and fatty acids. Paulit-ulit nating din-discuss paano nagkakos ng change in the amount and rate of secretion of insulin ang pagtaas ng levels ng glucose. Okay, so what I'm trying to open up to you right now is that the different substrates that we take from the food that we eat, like glucose, will influence also the metabolism of other tissues, hindi lang yung pancreas and glucose. So merong specific na effect yung mga particular na mga amino acids, no? For example, specific na effect yung particular na mga fatty acids. Okay? Bile secretion. So right now, we know na yung bile, yun yung secretion ng liver na pumupunta sa gastrointestinal tract through the biliary tree para ma-digest ang ating kinain na taba. So it solubilizes the fat that we eat and helps in the digestion of the fat so that we can absorb the fat. But at the same time, those same bile acids will have direct effects on metabolism once they reach the blood. Okay, so hindi lang pala sila pang tulong mag-digest, but also it regulates the rate, the proportion of the different metabolic pathways. And lastly, because the gut is home to microflora, especially the large intestines, the byproducts of this microflora and even the genetic processes occurring within those individual cells of microbes affect the brain, the liver, and the adipose tissue. So right now, they even know that the fecal composition, no? Kasi feces is what 50% by weight bacteria. The composition and relative proportions of the bacteria that is found in the feces of those with obesity differ from the bacteria that is found in the feces of those who are lean. Okay? Ibig sabihin, merong ginagawa yung bacteria that differ between the two subsets and how they affect metabolism. So here is an example of a drug that we use for the treatment of diabetes mellitus and obesity, which is a congener, which is an analog of glucagon-like peptide 1, so GLP. So here, in the first table ba to? Panel, we will see yung effect ng liraglutide, a GLP analog on body weight. So ito, makikita nyo, ito yung placebo. And then in the treatment arm, in the RCT, nung binigyan nila itong mga participants ito ng liraglutide, ito yung naging weight change nila. So humiwalay sila dun sa placebo, and this is the extent of the weight loss. Okay? Then makikita nyo, meron pang difference if dito sa weeks later, hihiwalay yung merong pre-diabetes sa those with normoglycemia. Which tells us na merong change that occurs in the physiology of those who are to go into diabetes that affects the metabolism in the fat tissue. Okay, that makes their response to liraglutide, a GLP agonist, different. Okay, so dito makikita natin percent patients and then weight loss. So, of course, marami yung merong minimal weight loss, but still significant na 5%. So 5%, 67. So dito sa bumalik sa So dito sa may minimal weight loss, mas malaki pa rin yung proportion ng patients na nagkaroon ng weight loss with liraglutide. Ito naman tayo sa kabila, and this shows us the extent of glycemic control. So dito tayo sa HbA1c na magsasabi sa atin gaano kadami yung sugar na dumikit sa red blood cells, which tells us the chronicity of the hyperglycemia. Okay? So ito si taglitin. If you will remember this one, ito yung gamot na nagpe-prevent na ma-degrade yung glucagon-like peptide 1. Okay? And liraglutide is a drug na kamukha mismo ng glucagon-like peptide 1. So both of them will have GLP effects. So kinumpare nila yung effect on decreasing the blood glucose noong GLP agonist mismo and yung indirect agonist. Ibig sabihin, pinapataas niya yung levels ng glucagon-like peptide 1. So here, makikita nyo na after giving the liraglutide, the HbA1c from the starting point of 8.5 went down to 7. What does that mean? Tingnan natin yung equivalent nun sa blood sugar mismo, no? So they started here at 180, and once they gave liraglutide, it went down to 140. So that's a 40 milligram reduction with the use of just gastrointestinal hormone, which, if we will review this lesson, potentiates the effects of insulin at the same time, forces the pancreas to release more insulin. Okay? So yun lang yung lesson natin. Do you have questions?